Assalamu alaikum. We're delighted to start our second session in the conference today. The session is focused on several important issues in the area of pathology and especially in cancer care. Quality and response to treatment, and also digital pathology. And it's an honor to present our first speaker today. He is Dr. Aaron Han. Dr. Han is owner of ASA Labs in Dubai. He's the Chief Medical Officer of Alliance Care Technologies, visiting Professor Mohammed bin Rashid University of Medicine. He's a champion of lab and hospital accreditation and Deputy International Commissioner for the College of American Pathologists, the CAP. He received the 2023 Lifetime Achievement Award from the CAP for his work in advancing inspector training and monitoring team leaders. He was part of the leadership that established the first Mayo Clinic Care Network hospital in the Middle East. He's vice president of the Emirates Pathology Society and board advisor to the Biologic and Physical Science program at the American University of Dubai. Dr. Han, we are delighted to have you today, and I'm sure we will all enjoy your talk. Please.
Thank you, Sabah Khair Waful. It's always an honor to be in Egypt, and thank you for Dr. Manal and the team for inviting me to this wonderful event. The scientific quality is so high, so I have two challenges. One is keep the quality of the talk very high, and also the second is time control. One of the things that's probably more difficult than delivering a good talk is to make sure you stay within the time limits. So I will be talking about a subject that is very near to me, and it has to do with quality in the anatomic lab. And as you know, I work with CAP in the region, but I also want to acknowledge Dr. Samir Amr, who really is the grandfather of CAP in the Middle East. We probably would not be talking about this type of program or quality were it not for his influence, his training, and his encouragement to most of us who are part of the CAP journey. This is my summary. The objectives relate to the updates and in anatomic and cytopathology requirements, so these two areas, and then we'll talk about what are changes that are needed to make sure your lab practices quality requirements in order to make the right diagnosis and also have quality material for you to examine. And then some practical solutions that are from frequently cited deficiencies or NCRs or non-conforming events, and then some of the frequent asked questions during a CAP audit, and then we'll talk about some new trends in the CAP. One of the things when I was sitting in the first session, and I think most of you were noticing, not only was the science good, but the images were superb. I actually will not be showing any slide images, but to get a superb image means you have to have a quality lab. If you don't have a quality lab and good practices, and that's taking away some of the uncontrolled factors such as pre-analytical factors you cannot control. But if you don't have good quality practices, you will not have images that you can show in an international meeting. So the fact that many of the presenters have shown that means that type of quality is achievable. How many people are practicing in a CAP lab at this time? Okay. Hopefully the next time I visit Egypt, there will be more hands raised. How many people are aware of CAP resources or participate in either CAP, EQA, or educational activities for SurgePath, PIP, or maybe the gynae surveys? So these surveys are accessible, and there's also other free resources on the website that you can access. Many of the forms that I will talk about today, there's no charge to use a lot of the resources. The other thing that CAP provides is every month there's a free digital slide case that they send every month. So I get a case every month. The last month it was an ovarian case. And many of these are scanned digital slides, so you can review the slides. They're cases from past years, and it gives you usually 1 of 4 answers with a discussion. So there are many resources that are related that you can use. When we go through a CAP inspection and audit, every time then the findings are submitted to Chicago and then they're entered into the computer database. At the end of every year, for every one of the checklists, there's a tally and summary of the top cited deficiency. So this talk is based on the top 10 cited deficiency, or the most frequent cited common findings and gaps in anatomic pathology as well as cytopathology. So these are the 10 areas, and not all of them will apply to your practice. The most frequent one has to do with competency assessment of non-pathologists, so non-physicians who put in specimens or do the gross examination. So that's probably the most frequent citation, and this is the number of times that was cited in I think this is 2022 end of the year data. And then cryostat decontamination is the second most frequent one. The requirements for cancer protocol use and synoptic reporting, professional competency assessment of pathologists, labeling of FNA reagents, staining and changing of the reagents, the requirements for amended report and the elements, the comparison studies for HER2. Number 8 is breast predictive marker. These are pre-analytical requirements, cold ischemic time, fixation time, storage requirements, and then feedback on the preparation of the sections. These are the top 10 for cytology. The first one has to do with recording and limiting the workload of screening staff, the keeping of statistical records for 9 gynae cases, how you communicate the significant findings. This is related to critical result findings. So some institutions, you may have a critical result list. Many places for anatomic and cytopathology, we don't use the word critical results. We use significant and unexpected findings. And then criteria for unacceptable non-gynaes, gynae statistical records. So these are 2 separate statistical records for non-gynae as well as for gynae. Again, storage requirements, stains requirements, elements of the reports that are required, a policy to prevent cross-contamination of cellular versus other specimens, and then this is a repeat. Unacceptable non-gynae, unacceptable criteria for gynae specimen. So let's start, and I'll go through some of these, but I will focus on the ones that are probably most relevant to your setting. How many people do gross examination and submission of specimens in the room? Okay. And all of you are physicians? Any non-physicians in your practice that put in specimens? Usually in the Middle East, this is not a common problem. This is more common in the USA, where there are physician assistants, sometimes technicians that put this through. So I won't spend much time on this requirement at all. In the cases, many of the settings, the non-physicians, they only put through small specimens. And in some of the times, if they only put through GI biopsies, skin biopsies, cervical biopsies, they just have to count the pieces. And then they put the piece from the pot into the specimen container. So usually I will tell the lab, you have 2 choices. You can put a competency assessment program together, or you can redefine that process as tissue transfer. That's not a significant gross description. The exception I make usually is when it comes to skin, especially pigmented skin lesions. I usually require some kind of monitoring training, because you probably have one chance to make that good diagnosis if it's a small pigmented lesion or it's a small biopsy of a larger melanoma, for example. You don't want to have the doctor go back and do another biopsy. The next procedure either is an excision or the patient is fine. Everyone understands that? So if you're doing tissue transfer, I don't call that gross exam. Gross exam is significant tissue, so usually it's a skin biopsy. Even a small skin biopsy should be properly oriented, properly sectioned, and then other cancer. So like a cervical cone, that usually requires some monitoring. You should not have an untrained person put in a cone biopsy. There should be some monitoring, some training, some competency assessment. So I won't spend much time on this because most of the time this is a duty performed by pathologists. But if you have other technical staff, and I do know in some places histotechs do perform this, then either choose to define that they only put in tissue transfers, so they're not touching they're small biopsies and they're just transferring from the formalin into a cassette. The second one is decontamination of cryostat. So how many labs do frozen sections? Okay. So with this one, you need a policy when you have incidents where you're concerned about contamination. Usually the two incidents I come in most frequently am concerned about, one is infectious agents, and the second one is brain biopsies. So any patient at risk for slow virus CJD, I need to see your policy. You need to define it. If you say, well, we don't ever touch brain biopsies, then your risk is very low and your need for that is probably not as critical. But the policy should define the decontamination intervals, how frequent, and when you do decontamination for your cryostat, your frozen section machine. And then you have to have evidence of the decontamination record. So set a schedule, follow the manufacturer instruction, and make sure you document when you do this. So everyone understands, typically you need to have a policy. Usually I would expect to see it, when was the last time you had a caseating granuloma that you cut on your cryostat? What did you do after that? Did you have a brain biopsy? What's your frequency of brain biopsy in your laboratory? So those are usually the questions I would ask about your cryostat and your decontamination. The third requirement has to do with the cancer protocol and synoptic report of cancer cases. So these usually relate to definitive resections. How many people are aware of this synoptic report? It's on the CAP website. So it's a free resource. You go to the CAP website, there are reports, and there's a cancer synoptic report. These are updated regularly, and they reflect the best and the newest updates for the staging, as well as there are often notes to help you define some of the parameters in histologic findings. So I always use this. Now the requirement in the past is that you have to use this, and again, if you're not CAP accredited, then it's not a requirement, but if you are going to be accredited, this is a requirement that you use this, and you also audit that you're using the elements in the proper format. But even if you're not currently CAP accredited, this is very helpful, because when your report goes to the oncologist, they will usually look at the synoptic report, and it has all the elements. You never miss anything. You never miss the measurement, the TNM grading, the way to stage the lymph nodes, so those are always accurate, and it always reflects some of the newest findings in many of the tumor types. So I often go back and look at, for example, people report colon cancer, right? You report colon cancer. So tumor budding score. This is one of the things I always go back to the checklist. What are the criteria for tumor budding, because it's a predictive marker? Or tumor spread through air spaces for lung cancer. These are some of the things that are reflected in the checklist, and they may not always be reflected in the TNM. So they're very important because they also relate to the prognosis of the case. So this is an example from the website, and this is usually the header. This is the case of a resected specimen for DCIS. So you can go to the website. They're based by the organ systems and usually all the different tumor degrees. So in situ, invasive, and then usually epithelial tumors may be separated from sarcomas. There are also biomarker templates. So there's a very good ERPR template. There's a good template if are you doing biomarkers for colon cancer, many of you? So you may do the immunos for colon cancers as a reflex. So if you're doing MSI on IHC basis, there's a good template for MSI as well. So I highly recommend that. This is another area that is still evolving, and it has to do with professional competency of the pathology or the medical staff that reads the slide. Is this something that's familiar to you? Or how many people are part of Joint Commission hospitals? Are you in a JCI hospital? Yes? Some of you are in JCI. So in Joint Commission, this is referred to as ongoing professional activity or professional practice evaluation. So your medical director will call it OPPE. So usually they have a couple measures to see and make sure that your professional practice is matching in your department so that there's less variation from person to person. So they may assess professional competency. In anatomic pathology, it's a little more difficult because sometimes we use the term competency assessment, but we try to avoid competency assessment in physicians. So that's why we use professional competency or professional practice evaluation. And we also don't QC or QA pathologists. Okay, so if you or any of my administrators said one day he's going to do QA or QC on me, I will retire because our profession cannot be quality controlled. Okay, when we become just like a CBC, then we're in trouble. Okay, so that's why we need to be aware of this, because we need to take the leadership in defining what are the metrics that define a good professional practice in pathology. So this is the responsibility of the lab director, that we are competent and that our interpretive service are accurate. So some of this can relate to turnaround time, but it probably more relates to your accuracy in diagnosis. And it depends on the type of service, so if you're anatomic or if you practice a specialty. I don't know how many practices are specialty only. So you only do a certain couple of organ systems. Is that true, or everyone does everything, general, right? So some places are going to specialty, I think, like in neuropathology, you really need specialists in brain tumors. I used to be able to do brain tumors. Now I tell people I can't do brain tumors, or maybe I can do right side brain tumors but not left side. So, and it's getting very hard for me to do kidney tumors. Kidney tumors require so many stains. So if you practice and go to subspecialty practice, then these will be defined differently than for a general practitioner. But it's very important that we continue to take the leadership on these type of activities. And there's 4 ways you can meet this. You don't have to do all of them, but if you participate in a CAP educational program, that meets the requirement. So you're ongoingly being assessed against your peers in an educational program. If you have a peer review program, so you have internal random peer review of cases, metrics from quality reports or other individual assessment. The other thing I like to put in, so in many of the practices I use 2 or 3 metrics. One is frozen section. So how do pathologists perform on frozen sections, the turnaround time, and then frozen sections correlate with permanent sections. That's a good metric. It's very objective if you collect the data. The other one is if you do pap smears, I collect ascus-sil ratio on all my pathologists because I want to make sure that we're within a band so that we don't have some people calling 20% ascus and another pathologist calling 5%. So these are some of my criteria, but these are ways in which you can meet the professional competency requirement. I'm going to go very fast through FNA staining. In cytology, there's also the concern, make sure you have a policy about labeling, the open date, the expiry date, and your schedule for staining, and have a defined process and make sure you document. Amended reports is a very important policy. It depends also how you define amended, addendum, and all the different corrected type of reports. Nowadays, especially when cases are sent for additional ancillary studies, you have to define your process. Are you amending it after a second opinion? Or are you adding the ERPR studies? Are you adding flow cytometry studies, molecular, and NGS? And then if you notify the doctor because they make treatment decisions, let's say you're doing PD-L1 on a cancer, and you call the doctor and the PD-L1 may influence the chemo, you need to document all of those discussions. So have a policy, always have an example of the report of an amended one, and then have the records of the doctors that you discuss the results. We already had a wonderful talk on implications for HER2, and this will only get more important as we look into the HER2 low category, but now after Destiny 6 is completed, there's going to be the whole issue of HER2 ultra low. So HER2 is getting to be a bigger problem. And there are some updated resources on the CAP website. I think you should, I would recommend you go to that, but this is not going to decrease in importance. So if you do HER2 and ER markers, then you need to have annual assessment of how your tumors are ER/PR positive or HER2 positive. And there are benchmarks that you should strive for. So the vast majority of your tumors should be ER/PR positive. Usually I tell people your HER2 rate should be no more than 35%, but it should be somewhere probably around 15 to 20%. And then you can also assess your HER2 2+ percentage, as well as all the pathologists that read these have to be able to do side-by-side comparison. So everyone who reads ER/PR HER2, there has to be an agreement rate that is greater than 95%. So you need to collect these statistics so that when any person or any ER/PR report comes from your lab, it doesn't matter who's reading the result. So usually I recommend 1 or 2 people, and over time we'll see more of this being automated. So ER/PR will be using assisted scoring. And I think if you're working with any of the scanner companies or the IHC companies, they will offer you probably assisted scoring for your ER/PR, and this will probably take the importance of this. It will all be automated for you. HER2 will be very important going forward, and I recommend you enrolling in a HER2 ER/PR type of external quality insurance scheme, because it will also help you automate the process. But work with your vendor, especially if you're doing IHC in your laboratory. HER2 low is going to be a problem. CAP is starting to address this. In the past, we report HER2 3+, and then everything else was either negative, and most of the cases are very clear. There's some antibodies that are very good. There's very few HER2 2s in that antibody experience. But now we have the whole category of HER2 low. We already heard about it, and over time the HER2 1s will be an important problem to identify consistently. I think over time there will be 2 possible ways in which this is solved. Most likely it will be digital pathology with AI helping you on the HER2. So there are some projects that are going on. I can connect you to the people who are working with the HER2 low category, and they can assist you if you decide to go to digital and AI. The other one is coming out of Yale University, Dr. David Rim. He has a program that will basically turn HER2 into like a chemistry test. So he's going to turn it into a biochemical HER2. So actually you'll get HER2 quantity as a continuous measure as opposed to 0, 1, 2, FISH plus or minus, and 3. So I think those are the 2 possible choices. So historically we had HER2 IHC plus HER2 FISH, but I think going forward it will be either HER2 with AI assist or a biochemical type of HER2. But some of the other categories will be very difficult to assess HER2 1+. All right, this is very important because this will affect your ability to do the markers consistently, and this is out of our control. So especially if you get specimens sent to your lab, you want to know what is the coldest ischemic time, so the time that the tissue was taken to the time that it was put into formalin, and then the total time in formalin. But it's very important because this will affect your performance of your breast markers. So typically, if you have a low performance or you don't compare in your annual statistics to other labs, it's likely to be a fixation issue or the length of fixation. The other thing in my experience is whenever you do the immunohistochemistry, make sure your lab is cutting a fresh slide, because over time the controls will fade. So you cannot cut many, many slides, bank the controls for a lot of the breast markers. You need to have fresh slides. So monitor this and try to get agreement from the labs that send you specimens. If you work in a hospital, approach the administrator, talk to the surgical team, and find a way that you can involve yourself in getting the specimen from the OR to the lab, because then you will control a lot of the pre-analytical variables around this. I'm going to skip the storage solutions because of time. This is, I think, the last one for AP, and this has to do with the feedback. So how many people do some type of feedback on your histology and slide sections? This is very important. So there's different people in the room, they can share their feedback form. I usually have one. It may be thickness, the staining of the slide, whether the hematoxin is weak or the eosin is too weak or too strong, whether there are little ridges in the slide. All of those are good feedback for your histotech. The other feedback we give is if you have technical people that are doing transfers of specimen, we always have feedback from the tech that cuts the slide and the people that put in the specimens to make sure the numbers always match up and or the size. The other feedback that may be given is the thickness. So this is a feedback oftentimes my techs will tell me, oh, we can't give you the slide today. You put in section is too thick. So sometimes I'll get that feedback. So you know your feedback is working if you're giving feedback to your techs and your techs are giving feedback to you. Okay, because you cannot get good histology without good fixation, good staining, good processes. So feedback, and this is some of the areas that you want to seek feedback on all your routine stains, your special stains, and labs that may have different ways. You may have processing and then send to a central lab. Probably most of you work in the lab that does your processing, and you can just walk into the lab and talk to the technician. Sometimes I will actually want to see the block, because the other feedback sometimes I give is some of the newer trained histotechs, they're afraid they don't cut into the block. Okay, they're trying to save you and they don't want to cut through the block. And so oftentimes I'll go back and I'll see, oh wow, you're just getting into the block. And I would recommend, especially if you're young in your career, or you're in training, or you're a resident, learn to cut some specimens. Don't cut the small biopsies. Get a piece of uterus, learn to cut it. Or get a large piece of tissue, learn to cut so you know what the techs actually go through. I used to do that when I'm in training, so I can actually troubleshoot some histology questions because I know what they actually have to go through. So one of the things I most frequently give feedback is, you need to cut deeper because I don't see the lesion. Okay, so it's important to have the mechanism to give that type of feedback. Cytopathology, I will skip workload because this almost never comes up in most of our settings, but if you have to define the maximum number of slides, in the US where there's large PAP practices, usually they're doing 100,000, 200,000 PAP smears a year, then there has to be a limit to how many slides each cytotech will review on a daily basis. Non-gyn and gynae statistics I will mention together because it's important. For non-gynae, the minimum is you have to put the types of the non-gynae classification and you should put it by categories. And one of the key categories you should know is your unsatisfactory rate. You should know your unsat rate for non-gynaes, for your FNAs, and also for your pap smears. With pap smears, I'll talk about it now, it's important to classify your pap smears. You all use Bethesda, or do you use some of the UK? So if you use Bethesda, there are benchmarks for how many percent should be unsat, what percent should be benign. Ascus rate should be 5% or less, and Ascus-Sil ratio usually should be about 1.5 to 2. So these are parameters that you can compare to other labs that provide quality practices in pathology. How many people are doing HPV testing as well? Anybody, are you doing HPV? So if you have HPV statistics, that's a separate check. So I had one example, I was just auditing a lab, and their Ascus-Sil ratio, they went 6 months, no SIL. They had about 90 Ascus, but no SIL. I said, you need to investigate this because you're probably calling too many Ascus. Then I asked them, what's your HPV rate? They said it's about 40%. And I said, 35 to 40 is okay. For Ascus, if 1/3 of your HPVs, Ascus is HPV positive, that's okay. So most likely their patient population was such, there are a lot of borderline. Then I sat down and went through some of their Ascus cases and just to review their criteria. Usually what I find in most labs, if your Ascus rate is high, I usually tell people start with the postmenopausal cases. And then if you know your HPV rate, then correlate it with HPV, or if you know your biopsy correlation, most of the postmenopausal ascus are not HPV related. Okay, so that's one place to start. Or you look for infectious or other causes. Significant and unexpected findings. So in anatomic lab cytopathology, I recommend people don't use the term critical results. Because if you're Joint Commission or accredited by other agencies, critical results require a callback and a readback. So in anatomic pathology, I usually tell people, use the term significant unexpected results. And it's treated more or less the same, because in most cases, the most time-sensitive result is which result in AP. You know where it is? It's your frozen section. Okay? You need to get that result out in 20 minutes. Usually anything longer than 20 or 30 minutes max for a single specimen is too long, because you don't want that patient under anesthesia for that long. Okay, so it's even more critical. Critical results in most other lab studies is 1 hour, but in a frozen section, that's your most critical result. So if you want to have one critical result, it's for your frozen section. That's assuming your doctors are using it appropriately. And we talked about unacceptable, we talked about gynae stats. I'm going to skip storage, and we talked about staining as it referred to in the anatomic setting. These are required elements for your cytopathology report. You can take a picture of this, or it's in the CAP checklist. I won't go through all the details, but this should be in your report, all the different elements. Finally, I think this is the last one, is cross-contamination. You should have a procedure in your cytology lab to prevent cross-contamination. Some of the ways you can do this is listed. Actually, one of the most common ways to have a blank slide in between. So insert a blank slide between, oftentimes, your cytology, your gynae and your non-gynae run, or limit your non-gynae run to one run at the end of the day. That's one way some people do it. And then start with a clean run with a clean slide the next day. So if you segregate your cases, you can address that. We talked about unacceptability, and you need to define that. And there's some new resources coming out with validation and digital pathology. So that's for the future. So CAP website is a good place to start. If you need other resources, usually I think everyone knows Hani Alfie, who's the director of CAP for the Middle East. So he's a good resources for the region, and also Hyler, who's a technical advisor as well. Thank you for your time, and thank you again for the honor of inviting me to Onco Egypt.
Thank you so much, Dr. Han. We'll keep the questions for the end of the session.
We will move to the next speaker, Professor Maher Swire. Dr. Maher is currently the chairman of the Department of Pathology and Laboratory Medicine at King Hussein Cancer Center, Amman. He is the president also of the Jordanian Society of Pathology. Dr. Maher is board certified by American Board of Pathology in both anatomic pathology and clinical pathology, as well as cytopathology. He has more than 90 peer-reviewed papers on various topics of medicine and pathology, and wrote 2 textbook chapters. He serves on editorial board of several medical journals, and he is a reviewer for many international journals. Please, Dr. Maher. Dr. Maher will talk about the assessment of pathologic response of neoadjuvant immunotherapy. Please.
Thank you very much. Assalamu alaikum. Thank you very much, Professor Manal Al-Mahdi, for inviting me to this prestigious conference. And it's a pleasure seeing all my colleagues that I know even a long time before this. So thank you. Okay, so today immunotherapy is really, it's not moving, so maybe I should move it from here. Okay, so these are the objectives. So today's immunotherapy is actually taking the stage in terms of medical treatment for cancer. So basically, what I'm trying to do here is, first of all, to give you a basic overview of the immunotherapy and immuno-oncology and tumor biology. And then I tell you a little bit about how to assess the pathological response in cases after neoadjuvant immunotherapy and how to score it. Okay, so we all know that the T cells present the antigens here to the, the antigen presenting cells, that's the dendritic cells, etc., present the antigen to the T cells here in the T cell receptor. And there are many co-stimulatory and co-inhibitory signals. So two of the main or most important inhibitory signals are the PD-1 or programmed death 1 and its ligand PDL1, and CTLA4 and its ligand CD8 or CD86. And as you can see, these give negative signals to the cells. And actually, this is very important. And this is again just a cartoon showing that the antigen-presenting cells showing presenting the antigens to the T cells that are primed within the lymph nodes. And then after they are primed, like here, they start attacking the tumors. And the tumors secrete antigens because they have mutations. So they actually produce foreign antigens. Again, there are many stimulatory, that's moving backwards. Many stimulatory and like this here, the pluses and the negative. And the reason we have inhibitory signals is actually to control the response. And that's a physiological actually phenomena. We need to control the immune response. It shouldn't go unchecked. And that's why they are called also immune check points, and then we're using treatments that are, again, also important is the tumor microenvironment. And we can see the tumor microenvironment in here, containing the many types of immune cells, regulatory, etc., and effector immune cells, and the importance of these markers. So the PDL1 expression can be either epigenetically stimulated in tumor cells, epigenetic dysregulation and expression of PDL1, or it could be a physiological feedback in the immune cells. So what is immunotherapy is actually using monoclonal antibodies like anti-CTLA4 and anti-PD1 or PDL1, monoclonal antibodies here. These monoclonal antibodies, as you can see, they prevent the interaction between the receptor and its ligand. And if you prevent this interaction, then the inhibitory stimuli will be lost, and then the immune cells will be more activated. So checkpoint inhibitor monotherapy or in combination with chemotherapy, and this is just a list of its uses as a monotherapy against cancer. It's a long list. Okay, so there are, for immunotherapy, three biomarkers we could use actually now. The PDL1, which we test by immunohistochemistry only. And then we have the tumor mutational burden, which is measured molecularly. So high tumor mutational burden is associated with the response to immunotherapy. And then the microsatellite instability or mismatch repair deficiency. So we can assess the mismatch repair deficiency by immunohistochemistry. But the MSI, which is more or less equivalent, is tested molecularly. Okay, so immunotherapy started initially as a second-line therapy for stage 4 cancers, in particular lung cancer, and many other cancers now. In breast, it's used in triple-negative breast cancer as in stage 4. And then it moved to being first-line therapy against stage 4 cancers, especially lung, as we said. And then it moved to the stage 3 non-resectable. And now it's being used as neoadjuvant and adjuvant in early stages, lung cancer and triple-negative breast cancer. So it's being used now there is expansion in its uses. So to go back, actually, let's see, okay. So this is the immune checkpoint inhibitors that are being used now currently in clinical practice. And along with this, you could see the antibodies that are being used to assess PD-L1. There are various antibodies, and each medication on the top line is associated with its own assay and definition and how to assess, etc., etc. And it's a moving target, actually. As you can see in red here, the triple-negative breast cancer using this medication is now no longer used, no longer, because the approval for this medication has been retracted. So, and there is also an approval that is new for non-small cell lung cancer in early stages, stage 2 to 3A, as you see, with the assessment of anti-PD-L1 using this monoclonal antibody, the SP142. And so it keeps changing, so we have to keep up. So basically, we have in order to have good pathological practice is to do PD-L1 testing in the right way. And the right way is actually, as you see here, this is just a summary, use a validated assay and proper controls. Sample should meet pre-analytical requirements in terms of fixation, storage, etc. Consider the tumor assay specific differences, the pattern, and how to read it, how to interpret it based on the monoclonal antibody or the assay used in conjunction with the medication that's intended for this. And whether PD-L1 should be scored in the tumor or in the stromal cells as well, and whether it should be membranous. In tumor cells, usually it has to be membranous, but in immune cells, it can be anything, membranous or cytoplasmic. The intensity is not important in PD-L1 testing, and we have to exclude the non-scorable areas like, in situ or dysplasia, non-invasive tumors and non-tumor tissue. And we have to know that PD-L1 staining could be heterogeneous. So this is, in brief, how we do the scoring. The most important two actually are the last two, the combined positive scoring, where you actually add the total number of positive tumor cells and immune cells and divide them by the total number of viable tumor cells times 100. And it's an absolute number, and the maximum value is 100. And then we have the TPS or TC, which is tumor proportional score or tumor cell area. And that's the positive tumor cells, the percentage of positive tumor cells divided by all viable tumor cells. So these are the two most important scores. Now, it is known that we talked a little bit about the other biomarkers besides PD-L1. So we have MMR, which is mismatch repair deficient tumors. As you can see, based on actually trials, immunotherapy was approved for MMR deficient tumors. As you can see, the probability of overall survival is much better using immunotherapy. And the response, similar things here in this chart showing various types of tumor. And similar things about tumor mutational burden, as you can see here in blue, the response rate of tumors with high mutational burden after immunotherapy. And these are called, actually, it's tissue agnostic, meaning that we don't have to use specific tissues for these medications as long as we have this marker. Okay. So pathological response assessment is actually, since we are being asked as pathologists to do pathological response assessment, after using chemotherapy or radiotherapy, clinically they do radiological assessments in order to see the response and whether this treatment is efficient or not. Similar to this, pathologists are now being asked to assess pathological response after therapy, because, and you'll see why, because it's very important. So since immunotherapy is being expanded in its indications, and both adjuvant and neoadjuvant, so we have to know this. Now, just a few words, what is adjuvant versus neoadjuvant? Whether immunotherapy or any therapy, chemotherapy, similar things, similar concept. So basically here, you see in adjuvant immunotherapy, surgery is done first, and then immunotherapy or chemotherapy, if you want, is given later, and then we get the resected specimen to assess. No, actually, the resected specimen is done before. That's in neoadjuvant. In neoadjuvant, the treatment is given before surgery, and then the resection is done, and we get the specimens. I'm sure you're getting specimens of breast cancer being treated with neoadjuvant chemotherapy. So it's the same concept. But here, we're talking about immunotherapy. So you can see the difference, the surgery here before therapy and the surgery here after therapy. Okay, so there is also an expansion of neoadjuvant trials in the medical literature being used in terms of immunotherapy for all kinds of cancers. And you can see the number of trials of neoadjuvant here in the blue are actually increasing. And that led to FDA approval of neoadjuvant pembrolizumab in combination with chemotherapy for early stage triple negative breast cancer, and approval of neoadjuvant nivolumab and chemotherapy for early stage non-small cell lung cancer. And these are the reasons why we should do assessment. Evidence is accumulating in multiple tumor types that the percent residual viable tumor calculated on H&E slides in surgical pathology specimens can be used as a surrogate marker for long-term survival. And the long-term patient outcomes can thus be predicted in weeks to months when the definitive surgical pathology specimen is received. And pathological findings can help on the plan to guide adjuvant therapy decisions for patients. Okay, so what is the percent residual viable tumor? It's the amount of viable tumor divided by the tumor bed. And here is the crucial, very important step, which is where the tumor used to be. This is very critical in order for a robust consensus of the residual viable tumor assessment. Okay, that's the most important issue. Okay, so these are important also terms that we have to be aware of. PCR, which is pathological complete response, it means zero, like the breast, zero residual viable tumor. And the major pathological response, here the definition is not very clear for various types of tissues, but in general, it's less than 10% residual viable tumor. And as you see here, it says in melanoma, actually, this is for the partial pathological response, where it's more than 10 and less than 50. But that's for, the most important is really when you have complete pathological response. And as we said, why is it important? Because pathological complete response here and near pathological complete response here are associated with recurrence-free survival, while the no pathological response and partial pathological response are less associated with less recurrence-free survival. And this is again in another tumor. This is in Merkel cell. That was the first one in melanoma, and here in Merkel cell carcinoma, you can see pathological versus no pathological response. And this is in non-small cell lung cancer. And you can see the 5%, 0 to 5% residual viable tumor has the best overall event-free survival, while those with more than 80% residual viable tumor has the worst outcome. Okay, so there are many scoring systems, unfortunately. And there was a move to have something called pan-tumor immune response or immune-related pathological response criteria. And in order to actually try to unify the ways of assessing the residual viable tumor. So in immune-related pathologic response criteria, the tumor bed surface is determined using features that are common across tissues and tumor types. So if you use it across various tissues and tumor types, it would be a universal pan-tumor immune-related response criteria. So that's this pan-tumor immune-related response was actually led to the FDA approval of nivolumab plus chemotherapy in patients with resectable lung cancer. And it's, as we said, pan-tumor. And it was originally developed for the immune therapy. It was also used and can be used for also people using combination of immuno and chemotherapy. So a pan-tumor pathologic is needed because, as we said, allows for direct comparisons of relative therapeutic efficacy across different tumor types, and it provides a scoring system for tumor types that were not previously treated using the neoadjuvant, and it avoids different scoring systems arising within clinical trials that are subsequently difficult to implement by pathologists. So in order to have the same confusion, in order not to have the same confusion as we have with PD-L1 scoring, we don't want this to be repeated with assessment of immune response. So initially, it was based on the review of more than 500 patients on treatment specimens from more than 10 different tumor types and from different regimens containing anti-PD-L1 therapy. And there was actually consistent histologic features of immune-mediated pathologic response across the examined specimens. And the interreader agreement of having 5 pathologists actually at 10% residual viable tumor threshold was really very high. As you can see, the interclass comparison is 0.98%. So the implementation actually, as we said, it led to the approval of neoadjuvant nivolumab, and it was implemented in numerous tumor types, as you can see here, and across numerous treatment settings, as you can see here. Okay. So we come to the actual things. How do you measure the percentage residual viable tumor? So this is now a case of lung cancer showing lung at the periphery. And this where the tumor bed used to be the green line. And the residual viable tumor is within the blue line here. So actually, the percent residual viable tumor is the total area. The total area of this viable tumor divided by the original tumor bed. And again here, okay. Now this has been actually correlated with the previous radiology of these patients. The estimated tumor bed of the post-neoadjuvant resected specimens was compared to the size of the tumor on radiology prior to therapy. And as you can see here, there is a very excellent correlation between the radiologic dimensions and the pathologic diameter, with the correlation of 0.79, and the p-value is very high. Now, the most important thing actually is how to recognize areas of regression in the tumor in order to estimate that these areas were in the original tumor bed. So it has to be mentioned that the regression areas, for example, this is a lung squamous cell carcinoma. And this is a keratin pearl here surrounded by viable tumor cells. So that's viable tumor. While in here, this is a keratin pearl surrounded by multinucleated foreign body type giant cell reaction, and it's found in this area. So this indicates that the tumor, this is an easy case because of the keratin. So this indicates that this was actually, there was a tumor here, and this should be included in the tumor bed area. This, okay? But not all cases are, of course, squamous cell carcinoma with residual keratin. So there are many other features that would would allow us to recognize the original tumor bed in order to give an accurate, such as you can see here, the presence of tertiary lymphoid structures surrounding the viable tumor, if there is any. Tumor infiltrating lymphocytes, of course, granulomas, proliferative fibrosis, similar to wound healing, neovascularization, similar to wound healing, foamy macrophages, cholesterol cliffs, plasma cells. So these actually, as you see, they are a result of immune activation, tumor cell necrosis or death, or resulting from tissue repair in the area of previous necrosis. On higher power, cholesterol cliffs, giant cells, lymphoplasmacytic infiltration, interstitial foamy macrophages, fibrosis, lymphoid aggregates, and neovascularization. Now, all of these are easy for us pathologists to recognize and design them as areas of regression or pre-existing tumor, viable tumor, or a treatment effect. But the most important or most difficult one actually is fibrosis. Now that's creating a problem because in some neoadjuvant response criteria or schemes, they consider this fibrosis as tumor response. Not all types of fibrosis are considered tumor response, and that's the problem. We'll talk about it in a minute. So there is more here. This is a case of melanoma, and you can see this is regression, background normal lymph node. The presence of melanophages indicates the previous presence of tumor. Again, proliferative fibrosis, neovascularization, plasma cells, hyalinized fibrosis, and cholesterol cliffs. Now, these are various types of tumors. TILs, the presence of T-infiltrating lymphocytes, tertiary lymphoid, as we said, and plasma cells, all of these in various types of tumor. This is renal cell carcinoma. This is more or less similar criteria across various types of tumors, Merkel cell carcinoma, vulvar carcinoma, cervical, etc. And these patients actually, after combined treatment with anti-PD-L1, and this is a non-small cell lung carcinoma, tertiary lymphoid structures, esophageal carcinoma, treated with a combination with chemotherapy, hepatocellular carcinoma, cholesterol cliffs, TILs, fibrosis. So the similar findings, more or less, are found in various types, even a basal cell carcinoma of the skin, found in all types of tumors. So it's really, more or less consistent findings regardless of the tumor type and whether the treatment was anti-PD-L1 alone or combined with chemotherapy. Similar features can be seen in the lymph nodes, as you can see here. Oops. Okay. So I said there is a problem when it comes to actually lung cancer, non-small cell lung carcinoma. The International Association for the Study of Lung Cancer, ISLAC, has their own criteria for the response. And as you can see, these many features are in common with the pan-tumor immune-related pathological response criteria. The common things are seen here. You can see in grossing, more or less, they have the similar requirements. Submit complete cross-section or the entire tumor, including tumor interface with adjacent normal lung. Photo can be helpful. The residual viable tumor reporting recommendation, they have this 10%, similar to osteosarcoma after neoadjuvant chemotherapy, right? And then their definition of the tumor bed is the same. Total area originally involved by tumor excludes other diagnosable, processes such as pneumonia, etc. lymph nodes, recommended quantitative. So they are similar in this regard. However, this is the differences. The difference is that, and as I said, fibrosis is the key issue here. So they actually, in ISLAC, their tumor bed components is the tumor plus necrosis plus the stroma. And that's the difference. Here, tumor, including intratumoral stroma, that is not regression. So if there is fibrosis like dysplasia related to the tumor, or fibrosis related to the tumor, not to the therapy, because as we all know, there are many tumors associated with dysplasia and some kind of fibrosis. Now in this system, they consider it stroma, not viable tumor, but here it has to be considered part of the tumor. That's the major difference. And the tumor is the same area of tumor epithelium only, so it's the epithelium without the stroma, and here the area includes the intratumoral stroma if it is not secondary to the immune response. And that's where the pathologist role comes. Okay, the stroma is area of inflammation and fibrosis, including intratumoral stroma, is not considered part of the tumor, considered part of the stroma, and here it's not applicable, of course. And the percentage regression over the regression bed not available here, and here it's the region of the radiographically and grossly identifiable tumor mass that have been replaced by wound healing response. So I'll show you examples. What does that mean? All right. So this first picture here is actually, it's 10% residual viable tumor here and here by both criteria. Okay. While this one here, this desmoplastic stroma is considered a response by the ISLAC, and therefore the residual viable tumor is 10%. While this is kind of fibrosis, it's actually desmoplastic response, is considered to be part of the tumor, and then there is actually 100% residual viable tumor by this immune-related pathological response criteria. Oops, this is very fast. I'm moving and you are moving, so we're both moving in one direction or the other. ده خلاص نحلها. Okay, so here is another example. So this is a lymph node containing metastatic tumor. And according to the, this, we have to determine whether this actually fibrosis among the tumor cells is really response, or is it like part of the original tumor. So that's an important issue here. And here is a higher power view, as you can see. Now this kind of fibrosis, hyalinized and thick, and it looks like it's more probably a desmoplastic response. So according to the ISLAC, this is a 10% residual, and this is a major pathological response, while in the immune-related, this type of desmoplastic response is actually part of the tumor bed, and part of the tumor, and therefore there is 100% residual viable tumor. So it really creates a big difference in the outcome of the patients. Okay, so is this kinds of measurement are really the residual viable tumor, or the so-called percent regression, that is the opposite of the residual viable tumor, that's the percent of regression in the tumor bed. Is it actually similar things, measuring the same things? Yes, because as you can see, the event-free survival by residual viable tumor here and the response is the same. They are measuring the same thing, and this is the 2-year event-free survival by percent regression. So pathologists can distinguish a treatment effect or the regression from in a similar way to residual viable tumor based on these criteria. So it is actually a good measure, this pan-tumor immune-related response. Let me use this. So in conclusion, I think we missed some slides. Yeah, we talked about this, right? Okay. So basically, in conclusion, the neoadjuvant immunotherapy is going to actually ask for pathological response. So pathologists are going to face these resected specimens, and neoadjuvant, whether immunotherapy or chemotherapy, is used in many types of cancer in order to actually reduce the tumor burden and downstaging, etc. And we're seeing this in breast always, but now we're going to see this in lung and other types of tumors, as you can see, melanoma, Merkel cell carcinoma, any type of tumor, renal cell carcinomas. So we're going to be asked to assess the pathological response. So a standardized pan-tumor scoring system will benefit patients and pathologists and will give a unified type of reporting. Histologic features of tumor regression are readily identifiable and support a robust calculation of residual viable tumor. Okay, and thank you very much. Finishing.
Thank you very much, Dr. Meher, for this great informative lecture. Now we're moving to the next presentation, and it will be held virtually with Dr. Laura Comerma Blesa. Dr. Laura is a breast pathologist at Hospital del Mar, Barcelona, Spain. During her PhD, she worked with image analysis. Her hospital started implementing digital pathology at 2013, and she got on board the digital pathology project of the department 6 years ago with special focus in breast pathology. Dr. Laura, do you hear us? Okay.
Yes, good morning.
Good morning.
I'm hearing you. I am not able to share my screen. I think it said that it's not allowed. Now, okay. Let me start by sharing the screen and making sure that you can see everything properly. Okay, can you see my full presentation now?
Yes.
Okay. Then, good morning. I'm Laura Comerma from Hospital del Mar in Barcelona. I'm a breast pathologist, and I'm going to talk to you today about the use and clinical value of digital pathology. First of all, thank you for being here today, and I hope you find this talk useful. These are some disclaimers for the talk, and these are the topics we are going to cover today. So if you're here in this talk, you're probably asking yourself, do I really need to go digital? I hope by the end of this talk you have enough information to help you decide on this. Let's start by remembering what digital pathology is. We all know that digital slides are created when glass slides are captured with a scanning device to provide a high-resolution image that can be viewed on a computer screen or a mobile device. But the important part of the definition is this one. Digital pathology includes the acquisition, management, sharing, and interpretation of pathology information, including slides and data, in a digital environment. I really want to stress this. Having digital pathology is not only having a scanner and digitalized images. It's important to keep in mind all the associated data that you are going to manage. You have probably seen this world map before, depicting the density of pathologists per million population. And we don't even need to see the map because we all know we don't have enough pathologists, as the decrease in pathologists is happening everywhere. Moreover, we have an increase in the number and complexity of cases, as we just have seen, so we are going to need help soon. And we will see during the talk how digital pathology can help us in this. So why must we consider digital transformation? So I would tell you that digital pathology or digital transformation will allow you to increase productivity by improving information management and workflow distribution and by integrating data. Will help improving diagnostic quality by ensuring quality of care and getting also faster second reviews and better access to subspecialists that are in your area or even abroad. And it will help with innovation by introducing image analysis and diagnostic algorithms. For sure, it also sets the scene for the use of AI-based predictive tools. This is a quick summary of the main difficulties we are going to face when adopting digital pathology and that we have to keep in mind. So you are going to be working with a large data volume. Remember that one slide at 40x is going to weigh more than a gigabyte. It's going to introduce changes in laboratory flow, so this can be a challenge. You also need to have a validation period to make sure that you're doing a right digital diagnosis. And for sure, there are many different systems, so which one to choose? This is a very important question and that has really many different answers. These are the advantages that you will encounter when adopting digital pathology, or at least some of them. First, you will get secure, permanent, and rapidly retrievable archiving solutions for your histopathological samples. You will be able to share images and pathological data with your colleagues. Also, you will be able to implement qualitative and quantitative analysis of images in pathological samples. This is maybe one of the best ones. I always say that scoring is boring, so if a machine can do it for us better and faster, why not? This is going to be achieved by introducing diagnostic algorithms that we will see later on during the talk. This was just a brief introduction, but let's move to the next part of the talk. I will start by talking about the transition to digital pathology, all the implementation challenges that you can encounter, and the importance of the adoption period. Digital pathology has very important implementation steps that you need to take into account. Key points when implementing digital pathology in your lab are the use that you are going to have in your lab for your digital pathology. This will define those that are involved in the process, the equipment that you are going to need, and the technical points. For sure, the amount of storage that you will need for your digital images. And all this is going to impact your budget, or be at least impacted by the budget that you have available for this project. When everything is already implemented, you will still have to validate the diagnosis in digital. This is just a summary, and we will talk about this in the next slides. But I wanted to give you this reference from last year in Modern Pathology, where you can find all these different items really well explained. Let's start with the uses of digital pathology. I think this is the most important point that you have to keep in mind. So the very first important question that you have to ask yourselves in your labs: are you going to use digital pathology for diagnosis or for second opinions? This is very different, or only for archive. Let me dive a little bit into this. If you need digital pathology in your lab for diagnosis, this is really going to have a big impact in your lab, because you will need to scan everything that is going out of the lab, all the slides, every day before the pathologist is able to work. For example, if you only need digital pathology for second opinions, you are going to probably only scan the difficult cases that you want to share with your colleagues. If you want it for education or for conferences, same idea. You will only scan the interesting cases that you want to share with your students. If you want to do image analysis or computer-aided diagnosis, for example, as I will show you later with the breast panel algorithms, maybe you're going to start only scanning breast pathology samples or other samples where you are able to apply some algorithms, and you will go on with your regular diagnosis for everything else. But if you want your digital pathology for archive, This is similar situation if you want it for diagnosis, but with some important differences. If you want it only for archive, maybe you can first diagnose everything under the microscope and then just pile up everything. And when you have time, you start scanning everything to having a digital archive of your slides and being sure that you never lose them. But if you want to combine both diagnosis and archive, you have to scan everything right away when it's going out of the lab, and then scanning everything to have all your work ready for the pathologist to work, and then this is already your digital archive. This is important because some hospitals only implement digital pathology for diagnosis, and they have a temporal archive, for example, for 3 months after the case is closed, and then they delete everything. So you have a really maybe a small digital archive because you're not keeping everything forever. But some departments implement both. So they do diagnosis in digital and they keep the digital slides for a long time, even forever. Maybe you don't have to delete everything. So it's important to think about that. Do you want digital pathology for research? So you are not going to digitalize your routine work, only the samples that you are using for research projects. So keep this in mind and really think about this question, because it will have a real big impact about everything that goes later on, as you will see. Then we move to the technical part, information technology. I was saying before that having digital pathology is not only having a scanner, is not only having your slides digitalized. You will need to have a scanner database, a laboratory information system it's integrating all this information, that it's going to work with computational servers. You will need a viewer because you can have everything digitalized, but if you're not able to view the images, you are not going to be able to work with them. And for sure, you will need some image storage, whether this is long-term or short-term, as we were discussing previously. In our case at Hospital del Mar, we started digitalizing some part of the routine around 2013, and we started by implementing a traceability system, having this integrated in our laboratory information system, which in our case is homemade, and this gave some problems down the road. And then when everything was already implemented, we worked with the UPath image viewer to being able to actually see and work with our digital images. The technical part continues with the scanner considerations. For sure, having a scanner is not enough, but it's an important part of the process. You cannot work with digital pathology if you don't have a scanner. So, do you need bright field images? Do you need fluorescence? Are you going to, depending on the case use that you are going to implement in your lab, are you going to scan everything? So you need a really big throughput scanner, or are you going to maybe scan only things for research or for education or for consultation? Then maybe you can work with a small scanner. Are you working with regular slides, or are you using mega blocks? We don't. We use regular slides, so we keep with the regular scanners. What magnification are you planning on using? Are you going to work at 20x, or do you need to go higher magnification for cytology or for nephropathology, for example? As you see, there are many different considerations that you have to keep in mind when choosing a scanner, and you need to start thinking about the use that you are going to need the scanner for, and this will define what type of scanner do you need, or maybe what type of scanner do you start with, and then you later on move to bigger scanners. So think about it. There is also in this work that I was talking about a really long list of the pre-analytic considerations that you want to take into account before implementing everything, because they have a big impact in the process. But I wanted to emphasize maybe some of them that are really easy to understand, and maybe only just to give you an idea of the importance that this has in the process. So my first maybe consideration would be it's really important to train the technicians. You need to involve the technicians in your lab, in your digital pathology project. They already know that the work that they do is essential in our labs, but you need to have them on board to implement digital pathologies, because they are a really important part of the process. Why? Because you need to keep in mind that cover slips, the staining protocol, the sample type. There are many things that can impact the quality of the image that goes out of the scanner. Probably if you are implementing digital pathology, you cannot stuff your blocks anymore, and you have to start grossing differently in smaller pieces because this is not going to be scanned because it's out of the field. So you could miss this part of the tissue and you don't want that. It's probably also going to impact how you embed the tissue. Maybe before you didn't mind having some parts close to each other, but here you need an order to be everything being properly scanned. Again, it's going to impact how you section your slides because you need to place the tissue for having an optimum quality in the center of the slide. You need to be really careful with your cover slipping because this it depends on if this is being done in a machine or manually. Sometimes the cover slip it's a little bit going outside the slide, and this can be a problem because it can get stuck in the scanner, or it can even break inside and have technical problems inside the scanner. So remember that there are many specific details to take in mind and that you have to adapt your laboratory flow. But this is only going to be achieved if you have your technicians on board. Moving again, continuing with the technical part, quality control. Even if you do everything that we were just commenting properly, you'll need to take into account that you'll need probably to have some technicians dedicated to review that the slides are being scanned properly and that everything is in focus, that this slide is not good, it's not passing your quality control, it needs to be re-scanned again, because otherwise this is going to be sent to the pathologist and he or she is not going to be able to work with that. This for sure, as you are seeing, maybe you are going to implement a small scanner, a big scanner, you are going to change the laboratory flow. So you are going to probably plan where are you going to place everything in your lab. And also you will need to plan for storage, not only for the physical slides and the physical machines, the scanner and everything, but also for the digital storage. After all this, you see that you have to do a really proper cost analysis, and you have to keep in mind the hardware that you are going to use, what type of scanner, monitors, what type of workstations, the software price, the maintenance and support contracts of all this machinery, the personnel that is going to be involved, the technicians, but how many of them, it depends on the scale of the digital pathology project that you want to implement, and the storage. Again, the glass slides, are you going to keep them also later on, or now that you have digital images, you maybe keep your glass slides less time? This sometimes depends on the regulations in your country, but you also need to think about all the storage for the digital images. Once you have implemented everything, you still have to train your pathologists for doing digital signing, digital diagnosis. And for this, you need to implement a validation period. Luckily for us, we have some recommendations from the College of American Pathologists and the Royal College of British Pathologists that recommend a validation period with some, and they'll even give you the type of cases that you need to review in parallel under your microscope and digitally before moving on to the only digital diagnosis. How many cases, which type of cases, which type of stainings, etc. And it's usually thought that pathologists take about 2 months diagnosing digitally to feel comfortable and to feel secure to move on and keep diagnosing digitally later on. So these are some of the things that you need to keep in mind. So now maybe you can move to the benefits of digital pathology. And I will try to share with you my own experience with digital pathology as a breast pathologist at Hospital del Mar. So in my experience, digital pathology is a support for diagnosis. It's important to remember that it's not doing your work for you, it's helping you do the work you do better and hopefully faster and with more quality. So you will have instant access to digital cases and case assignments. So if I am in an intraoperative consultation and I have the tumor specimen under the table and I need to assess whether I think this is the tumor or not, I can instantly go to the diagnostic biopsy, review the morphology, review the special stains, and I can have an instant review of the case and all the previous patient study without loss of time or quality. If the case was recent, maybe we can physically go to our physical archive, take the slides, and maybe this takes only 10 minutes, go and find the case. But remember that sometimes cases are older and you don't have the actual physical slides in the same hospital. So having everything digitalized is really useful. Also, annotations are recorded over time, and one important thing is that quality is not lost. So these digital slides do not fade as the physical ones do after some years. For sure, you're going to be able to take pictures and share them with your colleagues, students, at conferences, anywhere that you like. Moving to the case of digital pathology in breast pathology, if you see when we apply digital pathology for the ASCO-CAP criteria evaluation, there are many parts of the protocols that involve measuring size, area, different things, where being quantitative and being accurate, it's important for the diagnosis. So this is important. Digital pathology is a support for diagnosis. It helps you in accurately measuring a tumor that, as we can see here in the slide, the distance to the margin. If there is a second foci of tumor in this area, then we can still measure the distance to the new margin, etc. So I really like being able to do these precise measures, because before that we were doing, and sometimes when you use the microscope, we still do, you were marking with a pen, with a really big pen, this area, and maybe with a ruler you measured directly in the slide, or you had maybe some measurements in your microscope and you had to do calculations and adding and subtracting to get the proper measures. Now with digital pathology, this is for sure easier and more precise. And this is going to be important for measuring the size of the tumor, the distance to the margin, and the status of regional lymph nodes. In this case, when you have a metastasis in the regional lymph node, as you see, and as you already know, in breast is different from other organs, and you need to assess whether you are seeing less than 200 cells or less than 0.2 millimeters, then you would have isolated tumor cells. If this is up to 2 millimeters, you're having a micrometastasis, or otherwise, when it's up to more than 2 millimeters, this is a macrometastasis. So this is really easier with digital pathology, where you just click here, move your cursor, click here again in the last cell, and you have the right measure right away. So this is really useful. It's really nice also the simultaneous review of multiple markers in plyometric areas. The things that I like from digital pathology is when it allows us to do things that we are not able to do with our microscopes. It has to be at least as good as your microscope, but it's also better than your microscope in many different ways. So in this case, in your microscope, you cannot see many stains at once. You have to place one slide, then place the next one, find the same difficult or problematic area, probably mark it with a pen. In this case, you can always open different viewers and you can synchronize the image, and when you move this one, everything is moving at once, and you can decide whether you're having, for example, in breast cancer, myoepithelial markers in one area, to decide whether you are in an in situ area or in an infiltrating component. So this is helpful, and it's usually also helping you go faster reviewing these cases. Another thing that your microscope is not going to allow you to do is having this nice panoramic view of the whole slide. So in this case, if you're a breast pathologist, you're already seeing, even at this low power view, where you are probably not being able to assess things really properly, but you see clearly that this is the infiltrating area that is probably extending up to here. There is some in situ component extending beyond this area, and you can see that the margins are really clear. If you want, you can measure distance to the different margins. So for sure, you're going to go deeper and look at at it closer and doing the regular diagnosis. But with your microscope, even at 2x, you're probably only going to have a partial view of the specimen. So I really like this panoramic view. You were talking in the previous talk about evaluation of response to neoadjuvant treatment. In the case for breast, you know that it's involving area calculation, that it's something that it takes some time to get acquainted with. We were using the Miller Pain system quite a few years ago, but then maybe 5 or 6 years ago, our oncologists started asking for the residual cancer burden evaluation of the response to neoadjuvant treatment. And for this, you need to take into account many different measurements again. So you need to measure the area of the primary tumor bed in millimeters in 2 dimensions. Also, you need to assess the overall cancer cellularity as a percentage of this area. Again, the percentage of cancer that is in situ. And as we were discussing, not only the number of positive lymph nodes, but the diameter of the largest metastasis. So having these accurate measurements is helping you. There is this nice protocol from the MD Anderson Cancer Center with its really explaining in detail how you are going to do this. But it's different doing this under the microscope when you cannot see everything at once, or having your slides scanned and being able to do this composition of all your different sections that you would have in 3 different slides, and then doing precise measurements in each of them to assess the area that it's problematic, the percentage of cellularity that it's occupying this area, maybe the largest tumor deposit that it's going to be your T stage. So this is also really useful with digital pathology. Moving to the diagnostic algorithms for biomarker analysis, first we have to understand how the system is working. Then these systems need to first identify the problematic area. Sometimes some algorithms do this for you, and they already are able to, for example, distinguish what is in situ or normal or what is carcinoma. For example, other types of algorithms, you need to direct the algorithm to the areas that you want to analyze. In my case, I usually have to go to the tissue and say, okay, this is in situ disease, please don't measure this, and measure something that it's in other part of the slide where you will find the infiltrating component. Then when you have the problematic area defined, you identify, the algorithm identifies the number of cells through the identification of the nuclei. Then it classifies the cells based on the type of nuclear or membrane expression, as you will see later on. It calculates the result, and then it's your turn to do to check that everything is correct, that you are really trusting the evaluation of the algorithm. And we will talk about this right now. We will start with the first and easy nuclear biomarkers for estrogen and progesterone. This is only an example with a really bright staining to show you an image, because if you have this result, you don't need the algorithm to tell you that this is close to 100%, 99, 100%, what you feel comfortable with this. You don't need help in this. But this was to show you that when you select an area, you won't get a result that it's blind. You can always go and see what the algorithm is detecting for you. And then you need to validate that you trust this decision of the algorithm, or otherwise do your own measurements, or maybe change to a different area where the algorithm is going to work better. So my main message would be probably never trust the algorithm blindly. You need to apply your judgment as a pathologist. Remember, this is helping you doing your job. This is not doing your our job for us. Moving to the maybe a little bit difficult one, the Ki-67 proliferation marker evaluation. The thing that I like in the algorithms is that you get also a view of the whole slide. And now, for example, in UPath, in this software that we use from Roche, you get in the next version a heat map, which is really useful. This is you cannot see this here, but you will see it a few slides from now. I will remember to look at it later on. But remember, you can see a heat map that helps you decide the different areas that you are going to measure. For Ki-67 in breast, you are supposed to find 4 representative areas in the specimen. Depending whether the staining is heterogeneous or homogeneous, you decide where to put these areas for calculation. And with a heat map, this this is easier also to find. Again, you place your areas, then you go and review that the staining is good and that the algorithm is give you a result that you trust, and then you get an accurate measurement of the Ki67. Moving to the membrane biomarkers, HER2, again, same idea with the estrogen receptor. For this 3+ specimen, you won't apply the algorithm because even if it's really fast, with you only looking at this once, you don't need to apply the algorithm. But for low cases, know that you know the importance of the HER2 low story with the Destiny Breast for a clinical trial where also when you can maybe have some patients directed to trastuzumab deruxtecan treatment in the metastatic setting. We are going to be asked more and more to define not only the positive and the 2+ where you are going to do the reflex test, but you are going to be asked to differentiate really good the 0 cases from the 1 cases, because this case is still in the metastatic setting, being able to sometimes access treatment or to access some clinical trials, and these cases still are considered truly negative. So remember, in this case, the algorithm that we have now, maybe in this case you don't see a clear answer if this is 1+, 2+, it's difficult to see even when you're looking at the staining. So the algorithm right now, even by just emphasizing the staining and giving you an idea of the different type of staining that you see, whether it's complete or not, maybe in this case you can decide, okay, this is complete in less than 10% of the cells, so this is 1+ staining. Even if the algorithm is not giving you the exact category, just by emphasizing the staining, this is being clear to you to decide. And at the end of this year, they are introducing a new algorithm where you are going to be able to distinguish better these low categories. Moving to the HER2 dual-ish, again, here is where I wanted you to direct your view to the heat maps. It's really useful to have the heat maps guiding you towards the areas that you have to count. In this case, the algorithm selects the best 20 cells for you to count, but you are still able to see, okay, I don't trust this one. This is not the one that I wanted to measure. Please delete one and add this new one that I prefer to measure. But the algorithm is doing these countings for you and gives you a value, and it seems that this is really helpful. In this specific area, there are already studies. This is a study from this same year, histopathology, at the beginning of this year, where they selected a cohort of patients and they enriched this cohort for the less common patterns of HER2-ish. They did the staining of the methoxylin, immunohistochemistry, and the ISH, and then had some pathologists doing a manual scoring, everything that we do routinely under the light microscope. And then after a washout period of some weeks, they looked again at the same cases, but with the aid of the ISH algorithm. And they see whether they were concordant with their measurements initially or whether the algorithm helped in some way. And they found that when they looked at the cases under the microscope, the agreement was fair moderate, so there was a significant inter-observer variability that improved when the pathologists were aided by the algorithm. Then for HER2 group designation, had the same idea. The algorithm improved the concordance for the group designation, especially in groups 2, 4, and 5. Some of the things that the pathologists noted was that the time to enumerate the cases was also significantly reduced. You only have to decide whether the cells that the algorithm selected are the correct one, that you agree with that, and then the measurements are done. So that's why it's faster. So it's important that they found that the use of a digital image analysis algorithm significantly improved pathology concordance in the reporting of the HER2-ish status. So this could be important and a potential to improve therapy selection and outcomes for these HER2 low and borderline HER2 amplified breast cancer patients. So it's important to keep in mind, again, the same idea. These algorithms are not doing your job for you. They can still be mistaken and you have to correct them, or maybe just say that you agree with them, but they are helping you do your job better and faster. Some other things that are useful to work with in digital pathology are when you are working with different hospitals. In our case, I work at Hospital del Mar, right in Barcelona, right in front of the sea, as you can see in this image. But I have in my department also another associated hospital with. So some of my colleagues are some days, some part of the week are working in the hospital, and maybe some other days of the weeks are working in a hospital that it's maybe 50, 60 kilometers from here. Sometimes we want to consult cases from that we are going in different hospitals, or we want a second opinion from an expert that is placed in another hospital or even in another city, another country, and so on. So you get instant access to expert consultations. You can even do remote interpretive consultations, and in some special occasions, if your hospital allows for it, you can even do remote working from home without having to have a microscope at home and moving your slides from the hospital to home, which is not permitted. So you can work remotely only by connecting through your computer. Finally, we have at Hospital del Mar also been working for quite some time now with this tool, which is Navify Tumor Board, for preparing the tumor multidisciplinary tumor board in breast. This is an example where you can, with a program that allows you to collect patient data, coordinate and prepare the meeting, then we perform the tumor board, and it's also a tool to document decisions. In this way, you can have all the patient information integrated in one program, but as for us as a pathologist, as well as for our colleagues radiologists, it's a tool that allows you to select the key images. Here in this example, you'll see an image shared with the rest of the committee by the radiologist, and in this case, the pathologist decided to send some images to the tumor multidisciplinary board. This does not mean that we are sharing images every week, but it's useful for discussing cases of surgical margins, residual disease. Maybe there is some special subtype that it's not usual in your committee, and you want to share this with your colleagues, or you are having diagnostic difficulties with one case due to pre-analytics or any other thing. And sometimes an image is worth 1,000 words. So being able to show this in the tumor multidisciplinary board is really useful in many cases. So just to finish, I wanted to give you some take-home messages. I would say that digital pathology provides many advantages and improvements to the pathologist's work. Its implementation allows the adoption of AI-based tools, and these tools are mainly right now focused on biomarker evaluation algorithms. And it's important to have this idea. They provide support for the pathologist. They are not going to do your job for you. They are going to allow you to do your job faster, better, and with more quality by allowing objective evaluation of samples. Moving to the key points for a successful digital pathology implementation, remember, it's not just a scanner. Please consider that it's very important to define the expected use of digital pathology in your lab, because this is going to impact the participants involved, and it's going to define the storage solutions and the costs that this is going to have. Follow the steps to achieve technical implementation from all points of view. Please involve your technicians in the process. This is very important. And at the end, when you have everything ready, you need to validate diagnosis in digital, and keep in mind that you probably will need these 2 months for your pathologist to feel ready to diagnose. And also remember to doing this validation process following available guidelines that are really useful. So we started the talk with this question, do I really need to go digital? And I hope that after seeing all this information, you are now asking yourself, when are we going digital? Thank you for your attention, and I hope you enjoyed the presentation.
Thank you very much, Dr. Laura, for this great presentation. Yeah, the question is, when will we be going digital and not... yeah, you already convinced us, I believe so. Now we have 10 minutes for questions and answers with all of our professors and presenters. So the floor is open for question. Yeah.
Hello, Professor. Thank you for the presentation. I want to ask if there is any solution other than having a digital scanner for having the slide digitized and we can transform it from a place to another. Is there any solution other than having a digital scanner, like the camera over the microscope, that can transfer the digital slides over it?
Yes, you can. You have now these adapters that you can use whether you're using a digital camera. But remember that in this case, the image is live, so you have to take pictures. And maybe if you have access to some algorithms, you can then upload the image to this algorithm, and maybe have an idea of the evaluation in a part of the sample. But remember that some of the things that are good in digital pathology is that you can have this panoramic view of the image. And when you apply an algorithm with a whole slide image, usually the algorithm does its calculations before you look at the slide, so it's pre-analyzed. You don't need to wait for the image to get analyzed. Everything is pre-analyzed, and then you go and look at the areas that you want. If you have a camera, or even sometimes just your phone attached to your microscope, you will be able to capture parts of the slide. So you could still take pictures to share with your students, again at the tumor board and any other, to submit to a biomarker evaluation, but you're probably not going to be able, or it's going to take you more time to take all the pictures from only one slide to get the whole idea of the image. There are solutions, but maybe it's advisable to have a small scanner if you don't have the resources to get a big one. That's why I was thinking about the use. You don't need to start big, digitalizing everything. For example, we started 10 years ago, and we started with a small number of samples, and we keep moving up and up until now we have really big scanners. But at the beginning, we have only scanners for 5-6 slides and started from there. So my advice would be, you can always work with the digital camera, but this is going to be it's not whole image, so it's only an analysis of a really small part of the slide. So maybe you could try to get access to a small scanner and start from there.
Thank you for this lovely session. My questions are for Professor Han. I would like to ask about determining the cold ischemia time and time fixation of specimens. It's very challenging, especially in labs receiving specimens from outside the facility. So how do we determine the cold ischemia time, and especially in surgical specimen received from outside?
I think there's several issues. Are you getting any accurate timestamps at all? So I think
no, especially when we have a walking-in patient with a specimen, he doesn't know when exactly the specimen was extracted.
I think you have to do the best with what you have in terms of the specimen. Many times or often, it's a problem if the resected specimen is already the one that the patient comes with.
Yeah.
Then if it comes as a biopsy, you have a second chance to do it on the resection. So again, there's some work. I can give you his name, David Rim at Yale. He's created basically a baseline so that you can, based on other expressed genes and proteins on the IHC, it's basically a QC to show what the baseline is. So I think it's called an aquifer or something. I forgot the trade name. But that's probably the best we can do, because otherwise you have no way to assess. If you don't know the time, you don't know actually what the true ER is in that tissue based on an IHC. So I think the best thing I can offer is something like what David Rim has. So he gives you a baseline. The other thing you can try to do is if you do a Ki-67 and you somewhat know what the Ki-67 should perform at, or you do other types of markers. The problem is if you use a baseline for ERPR, you really want a nuclear stain as your baseline. So
Yeah.
you need to know what the baseline is in that fixed tissue if you don't have the time.
Okay, so
Yeah.
the cold ischemia time should be reported when I receive the specimen, yes?
The cold ischemic time and the total fixation time will impact. Usually the total fixation time, you could probably estimate based on if you know when the procedure was done. I don't know.
It
Dr.
can be an
Maher, you wanna add
estimation?
anything? Huh? You can somewhat estimate that the
Yeah.
time it's been in formalin. The patient may be able to tell you. You can try to put that together. The cold ischemic time, unless they can tell you how much time they were in the operating room, you may be able to estimate.
Okay, well, thank you. Yeah, this is a real problem. We're facing this always. The issue is, your most important specimen is the core needle biopsy coming from the breast.
This is true.
And I think it can be managed. I mean, you just need to communicate with the persons who are taking the biopsy to mention, it's supposed to be immediately immersed in formalin.
Yeah, the biopsy I think it's immersed immediately at the same session.
So your question is not on the biopsies?
Yeah, the surgical specimens,
On
the large
specimens.
specimens.
Yeah, forget it.
It can be difficult because it can be poorly fixed, right?
Yeah, absolutely. I mean, they are
This is a
the
very
amount of
true
formalin
problem.
is never the right amount of formalin proportionate to
Yeah.
the specimen. And, it can lay down in the operating room for 3-4 hours until somebody, the nurses. I mean, it's communication.
Yeah, we will try to do this, but if we fail to do this, is it accepted to have a disclaimer in the report about being received this specimen from outside of the facility with less data? Is it accepted?
Yeah, you put it as unknown, but to the best of your ability,
Yeah.
if you can put the procedure date and or time, that will help you get some estimate. And usually I would discourage people, especially unless you're running IHCs and processing on the weekends, discourage weekend surgeries. So try to do it at the beginning of the week. It'll minimize tissue that sits over the weekend. If you know you're not processing over the weekend, talk to your clients or whoever your surgeons are in the community and tell them, don't do it on the weekend because it can only prolong your time.
Yes, this is true.
But really, even in the hospital, you can have problems with large specimens, no formalin or very little formalin. It's just really a shame.
Okay.
The most important point actually related to this is not to encourage everybody to do pre-operative biopsies. I mean, sometimes it's like a fine needle aspirate where markers are not done. But if you're doing, true cut needle biopsies on every case
Yes.
before, the surgery, I mean, you don't need to do them on the surgery unless there are certain circumstances on the surgical specimens. And even in the hospitals, as Dr. Han mentioned, we get it in the same hospital. If it's done during the night or over the weekend, I mean, that's a
This will
real
make it
issue.
easier. Yes, this will make it easier.
Yeah.
Another question, a rapid question about the recommended time to report the critical or unexpected significant results in anatomic pathology. Is there a recommended time for reporting or for communication with the physician?
That one is usually defined by the lab. So there's no strict time. The other way you can also assess it is there's some CAP surveys. You can go back and see what the survey results show. It usually will show you the time to report and what the different practices in the different groups, and then you can benchmark your own activity. Usually it's within a day of when you get it, or if it's a new cancer. There are other specimens, for example, oftentimes in a uterine curetting, if you see fat tissue, usually that's something I want to call right away. So I'll pick up the phone, call my gynae surgeon or OB-GYN doctor and say, there's fat in an endometrial curetting, you should not see it. Make sure you follow the patient, you haven't perforated. I think the other thing is how many people actually get FNA of breast or FNA of axillary nodes for breast cancer? Are you getting FNAs?
Yes.
So I usually discourage people from doing that because usually it means if it's positive, it requires a second procedure. So the only FNAs I would accept in a breast case or an axilla is when they think it's negative. So a breast cyst, fine. You can stick a needle. If you think the axillary node is going to be negative, but if you think it's cancer, don't do an FNA. Go to a core. Or else, unless they're sending it from the outside, then it's fine. And then you say, next time you refer it to somebody in our hospital, then you have a better chance to control that ischemic time. Okay. So use it to make it better for the patient outcome. So that's what I would encourage.
Thank you so much, Dr. Han. Thank you, Dr. Maher. Thank you to all. Thank you.
Thank you so much for everybody, all the speakers. Actually, I have a question. Where did Dr. Is she gone?
She's still watching.
No, I can hear you.
Yeah.
You can still ask.
Yeah, I have a question for you, please. The thing is about the huge amount of storage space that you need for specimens and photography and all that. Would the up cloud then help? And how easy it is to retrieve it back and forth?
For us, it has been a matter of also regional regulations. So it means sometimes it depends a lot about if you have a regulation in place in the hospital. Some hospitals are not allowing for cloud-based solutions depending on because of security problems that we are having in many hospitals around Europe. So sometimes hospitals prefer in-home based solutions to store your images. Sometimes you have like a cloud, but only for some hospitals. So it's like a cloud, but it's kind of in-house. So it depends a lot. You really need to ask, because I could give you an answer, but it may not apply to your region. So I would advise to ask to your regulators in your hospitals and in your regions whether you are going to be able to use cloud-based services also for other health data. Because in Europe, for example, there are some regulations regarding sharing of data and cloud-based solutions. So please ask your region, because I wouldn't want you to give a false information.
I understand. But is it sky high? I mean, so expensive or just reasonable, or being supported by the hospital?
Yeah, for us it's being supported for the hospital and also for our regional government. So that's why I was talking about whether you want to keep your digital images or not, and that's why some hospitals are deciding to use digital pathology for review the case, sign the case, and then after 3 months that the case is signed, you delete, whether if you don't have enough space. It would be advisable in an ideal world to keep everything, but it's going to depend on the cost. That's why you need to define previously the type of use that you are going to have, because it will define not only the scanner, but the type of storage that you will need, and you will decide probably whether you want to keep few cases for longer. Maybe some hospitals decide to keep only the cases that are signed out as malignant and delete everything that is benign. Others decide to keep everything only 3 months. The lucky ones, when you have funding from your government or your hospital, maybe you can keep everything longer. But this again will be impacted a lot by the regulations and the cost that you have for this project.
Thank you. Dr. Maher, I have just a small question for you. Regarding the problem of fibrosis, whether this is reactive versus this is tumor being declined, is there any histochemistry that you can use to differentiate between the types of collagen, for example? Because it makes a big issue. Is this stromal reaction, or is it a tumor under effect?
Excellent question. So basically, I think it's like, evaluating the age of the fibrous tissue. So the desmoplastic response would be, inflammatory cell poor, would be very, hyalinized kind of sort of collagen, and then the fibrotic tissue related to the response, usually it's like wound healing type of fibrosis. So there would be neovascularization, would be some inflammatory cells sprinkled, but the presence of a histochemical stain, not to my knowledge, is being used for that matter. Just morphology.
I have a question for Dr. Laura. I think one of the models for starting on the digital journey is, as you said, starting with a low volume scanner. There's some nice single slide scanners. Does your center have any opportunity for collaboration? Because obviously early adopters will have an advantage. You have a larger slide selection. You're going to have more probably early experience with validating AI algorithms. Is that an opportunity for collaboration, possibly validating AIs or other unique breast cases?
We have been collaborating with many different departments, and maybe sometimes with visits to the department to know how we implemented everything and to see the different types of scanners that we have and the solutions and the challenges. Sometimes the visit is more useful for the challenges than for the benefits. When you start thinking about this, you already know probably all the benefits, but you need to be really realistic with the challenges that you may encounter, or whether you had problems with cost in some area that you were not foreseeing. So yeah, we have been collaborating with different departments at first by maybe sharing our experience. And in terms of validation of algorithms, we do some our own research to develop some of the algorithms, but are only for research use and to test whether we are in the right direction. But we also collaborate with companies to sometimes test algorithms, in this case with Roche, and we implement the algorithms. That's why also I always want to share this idea that you have to be very critical with the algorithm. Please never trust it blindly. It's your judgment as a pathologist is first, so you need to decide whether the algorithm is working well or not, because sometimes just changes in the type of staining or the type of fixation, some artifacts, so you need to be trained in how to use them and still at the end apply your judgment. So we have different type of collaboration in research setting, in commercial settings. So yeah, we are open for questions if you have questions in this area.
Any other questions? So thank you very much, our speakers. Thank you, Dr. Laura, for being with us. Thanks for the audience. And now we'll have like a 30 minutes break till 3 and 5. Okay. Thank you.
Thank you. Have a nice.